Hello, Clinic Review family. It's Dr. Sharon with Clinic Reviews. I'm so glad to see you again today. Today, we're talking about renal disorders. And I want you to remember that we are primarily an NCLEX preparation channel. Clinic Reviews, the greater organization that runs this channel, is an NCLEX preparation organization. It's not about teaching you content. I'm not here to teach you content. You're going to learn some content because when I teach, you do end up learning some content. But primarily, I'm teaching you how to think the right way in order to pass. I could be doing a video on renal. I could be doing a video on respiratory, GI, endocrine. It wouldn't matter. You answer the questions the same way as far as how you think. You have to be able to clinically reason through the questions, and that's what I'm going to focus on today. So let's go ahead and get started. Hello, Clinic Review family. It's Dr. Sharon with Clinic Reviews, the home of the very best NCLEX review in the entire universe, in my opinion. Mark Klimek is the GOAT of NCLEX reviews. Y'all, he has taught me literally everything I know about NCLEX preparation. And I'm going to teach you a little tidbit. The very last question in today's video is going to teach you a little tidbit that he teaches as part of his Clinic review, just to whet your appetite for the full 21 plus hour NCLEX prep. It's online, on demand. Mark Klimek himself teaches it. It's recorded, but it's an excellent program. It's the same as the 3-day in-person review that he does occasionally. He's getting close to retirement. I don't know how much longer he'll be doing that. And then we also have a streaming service where all of our videos, including any of the videos that I've deleted off of YouTube, like some of the older videos I've deleted off of YouTube, but they're still in our streaming service. So you can sign up for that if you're missing some videos you wanted to watch. And we also do Zoom tutoring, small group tutoring. So if you want to meet me live over Zoom, you can sign up for that. I do Next Gen, which is why I don't do it here on this channel. So by the way, I wore lipstick to church today, and it's just looking a little bright. It doesn't look that bright in real life. At least I don't think it looks that bright in real life. I don't know. Maybe I'm just not used to seeing it. Okay. A 68-year-old woman presents with dysuria frequency and suprapubic tenderness. Her urinalysis shows positive nitrates, leukocyte esterase, and bacteria, which finding most warrants immediate intervention. Temp 100.4, blood pressure 90/50, urine specific gravity of 1.03, mild costovertebral angle tenderness. So we have someone who presents with classic signs and symptoms of urinary tract infection, and we never are particularly worried or have to intervene immediately when they have the expected findings of the disease that they have, right? So she comes in with classic signs and symptoms of UTI. So the question is, how many of these are symptoms of the UTI? They're just more symptoms of the UTI. Temperature of 100.4, that's a symptom of a UTI. Blood pressure 90/50, that is not a symptom of a UTI. Urine specific gravity, I think that's high. I have to be honest with you, I don't have the normal values memorized, but I think that's high. Mild CVA, costovertebral tenderness, that is expected with a UTI. So the only one that's not expected is a low blood pressure. And so I'm going to pick that one because that's not expected with a UTI. Now you may say, well, but if she's got urosepsis, that's expected. Yes. She's got urosepsis. Of course, she's going to have a low blood pressure, but she didn't come in with urosepsis. She came in with a UTI. If she develops urosepsis, that's a complication of the UTI. That's not good. It's not a symptom of a UTI. Now, y'all, I don't know if someone was just, I don't know what they are doing. I got another message on YouTube, y'all, saying, Sharon, I like your channel and I used to watch it all the time, but you never know what the right answer is. And so I can't learn from someone who doesn't know what they're doing. Y'all, I am so good at acting ignorant. I didn't realize I was so good at acting clueless because I do know what the answers are. I write the questions, y'all. You've got to understand that I am teaching you how to pass NCLEX. I'm not teaching you content. NCLEX prep is not to learn content. You've already learned the content. You need to learn how to think the right way. Okay. So what I'm doing is I'm not telling you what the right answer is based on memorizing some fact, because passing NCLEX, you do have to have some facts memorized. And if you don't have many facts memorized, I'm pointing to the blue book over my shoulder here. You can get the blue book off of Amazon and you can memorize a bunch of facts that's written by Mark Klimick. I don't make any money off of it. And I also have a bunch of videos that go along with it here on YouTube. All right. So I'm not here to teach you facts. You graduated from nursing school. You already have, you know what you need to know. If you don't know it, get the blue book. I'm here to teach you how to think the right way. This is the key for most people who fail NCLEX. It's either they don't know their fundamentals. Okay. And if you don't know your fundamentals, you got to get the blue book, study your fundamentals, or you're not thinking the right way. And so here I'm focusing on thinking the right way because nobody wants to watch me teach you the fundamentals. Although I will say I have a bunch of fundamentals videos if you do want to watch some of them. A patient with acute post-streptococcal glomerulonephritis has periorbital edema, hematuria, and increased BUN creatinine ratio. Which prescription should the nurse question? Now we question orders that can harm the patient. Okay. All right. Sodium restriction, daily weights, IV Lasix, or scheduled protein intake of 1.5 grams per kg per day. So what's going on here? So let's say you don't know what post-streptococcal glomerulonephritis is, because I'm not here to teach you about like specific sort of isolated diseases, right? Yeah, people get it, but it's not that common. So I'm not, we can't know everything. Like it literally is impossible to know everything. So you have to figure out a way to read this question that you feel more comfortable with. So I'm just going to ignore the post-streptococcal and just say it's an acute glomerulonephritis. So glomerulus, okay, that's the filtering part of the kidney. Nephritis, that's inflammation of the kidney. So we have some glomerular problems. We have some nephron problems, inflammation. And so when I think about that, I think, well, there's probably some bleeding and blood in the urine. We've probably got some large particles in the urine that we don't normally have. Like we probably have some albumin in the urine because normally the glomerulus doesn't filter large particles. So when there's some glomerular damage, whether it's acute or chronic, you're going to see some larger particles like red blood cells, white blood cells, albumin in the urine. And we have an increased BUN creatinine ratio. So we have periorbital edema, which tells me they're retaining some fluids, which may not be that unusual if they have some filtration problems. And then hematuria, so that's expected blood. And then increased BUN creatinine ratio. So normally the BUN is somewhere between like 10 and 20, and the creatinine is 1. So normally the ratio between BUN and creatinine is 10 to 20. BUN to 1 creatinine. So anywhere between that is considered a normal BUN creatinine ratio. So if it goes up, that means the BUN goes up, but the creatinine doesn't. So what that tells you is you've got a higher nitrogen load, if that means anything to you, but usually it means it's not a chronic kidney disorder, but there's some filtration stuff going on, right? Because we excrete a lot of nitrates in our urine. So I go, well, all right, so that's pretty common. So we've got some inflammation, it's acute. So which of these could do maybe further damage to the kidneys? Which of these orders? Sodium restriction, is that going to further damage the kidneys? Well, no, they're already retaining fluid, so I don't see how sodium is going to cause a problem. Daily weights, well, if they're retaining fluid, I'm going to monitor them. That can't harm the patient. IV Lasix, I mean, they've got some kidney problems going on here. Lasix is pretty common treatment for kidney disorders. So unless I see something else, like unless nothing else can be the right answer, I'm going to not pick C. Scheduled protein intake of 1.5 grams per kg per day. So what I know is that protein is a larger particle. And because we have filtration problems, the more protein that a person takes in when they have filtration problems, the more protein they take in, it actually damages more the glomerulus. So I don't want a high protein diet. So the question is this high protein? So let's say you don't know. I bet most of you don't know. Okay. So we go, is it? And I go, is it more likely that Lasix is going to harm this patient or this dose of protein? And I go, it's so common that high protein diets are contraindicated, or we question high protein diets. And it just makes sense to me that D would be the one I would question, even though I don't have it memorized with the normal protein intake. So if you want to memorize it, it's 0.8 grams per kg per day. That's the recommended protein intake, 0.8 grams per kg per day, and that's normal. And then for someone who has kidney disease, you'd probably go a little lower than that, right? A little lower than that. So that's something you can remember if you want to. Otherwise, you may go, gosh, that seems like a lot of protein, and if, it just seems like the right answer, doesn't it? Like you just feel like it's the right answer. So trust your gut, and that's okay to do. A patient is in the oliguric phase of acute tubular necrosis. Oliguria means low urine output. It has a specific amount. I don't remember exactly what it is. I think it's less than 300 mils in 24 hours. I think that's what oliguria means. Of acute tubular necrosis. So I may say, well, I don't know what tubular necrosis is, but it's an acute problem. Okay, an acute kidney problem. The tubules, I know what the tubules are. So I go, well, the tubules aren't working right. Which order should the nurse anticipate? So they have oliguria, so they have low urine output related to some kind of kidney problem. Remember, you can't know everything. You have to be able to figure answers out without knowing everything, or you won't pass. All right, so I'm going to say, what are pretty standard orders for an acute kidney insufficiency? That's what this sounds like, an acute kidney insufficiency because of tubular necrosis. But it's acute kidney insufficiency. Strict I&O, that seems appropriate. Hourly urine measurements, that sounds good. Acute kidney insufficiency. Low protein diet, I like that. Remember, I told you about protein with moderate carbohydrates. Carbohydrates are fine. Moderate's fine. IV loop diuretic challenge. Well, I know furosemide is a loop diuretic. I know that loop diuretics are often given with kidney insufficiency, and I may not know what IV loop diuretic challenge means, but whenever I think of a challenge, what that means to me is we're going to give it and see how they respond. So I say to myself, would it be appropriate to give a loop diuretic to see if it helps in this case? I go, I don't see how that would hurt. Not that I know of. I mean, it's a kidney problem. Loop diuretics are given with kidney problems, so why not? So, okay. Potassium supplementation. So I know that when someone has an acute renal insufficiency or chronic renal insufficiency, they don't excrete their electrolytes very well. They have a tendency to retain potassium. And so I don't really like the idea of giving potassium here. So I'm going to say probably not. Daily weights and vital signs every 4 hours. Well, yeah, acute renal insufficiency. Why not? Did we not? I thought we already said weights daily, but we don't. We said I&O and hourly urine measurements. We didn't say daily weights. Okay. I like that for renal and vital signs. Yeah, sure. K-exalate, sodium polystyrene, PRN for potassium. If you don't know what K-exalate is an oral medication. It's a liquid that you take, and it promotes excretion of potassium in the stool. So if they have a tendency to go high, that would be an appropriate intervention. They probably won't have K-exalate on the NCLEX. They'll probably just have sodium polystyrene. That's the generic name for K-exalate, so you should know it. So I say if we have, because remember, I'm going with what I know. I'm not telling you to memorize what tubular necrosis is. I'm saying go with what you know. We know it's an acute renal insufficiency, so strict I&O is good, A. Low protein diet is good, B. Loop diuretic challenge makes sense to me. Potassium supplement is out. Daily weights is good, and K-exalate as needed for potassium, absolutely. So when you're doing, because you shouldn't just be doing questions with me, right? I'm teaching you how to think, and then you do your own database of questions using the strategies that I'm teaching you, right? So when you're doing this, it's not about memorizing the rationale. You shouldn't be going through the questions and then going, oh, I better memorize these rationale, because some databases have incredibly long rationale. And you probably know what I'm talking about, like pages of rationale, like it's over the top crazy. So you don't need to read that, y'all, because it's not about memorizing information for NCLEX preparation. First of all, if you get the answer right, don't read the rationale. You got it right. That's good. You're never going to get through the questions you need to get through if you read all the rationale for all the right answers. You only glance at the rationale for the wrong answer if you get it wrong. So if you get it wrong, look at the rationale, say, why did I miss this? Did I miss it because I just didn't know a fact? Do I need to know this fact? Did I miss it because I was overthinking, or I second guessed myself? Or did I miss it because I just wasn't thinking correctly, like Dr. Sharon told me to think? So you need to evaluate yourself and why you're missing questions without having to memorize a bunch of new information. A male patient returns from a TURP, transurethral resection of the prostate, with continuous bladder irrigation. You should know that's expected. Normally, they come back from a TURP with continuous bladder irrigation because they remove the prostate through the urethra, and it causes quite a bit of bleeding. His urine is bright red with numerous clots, and his bladder spasms are severe. What is your priority action? Increase CBI flow rate, administer antispasmodic medications, evaluate patency of the catheter, or notify the surgeon. So I can only do one thing. So the priority action means I can only do one thing. So that means I've got to say, if I can only do one thing, I'm giving report like this happened. He gets back from the OR like 6:30 p.m. and the new shift is coming on at 7 p.m. And I'm going to give report. I'm going to say, I did this one thing, but I didn't do any of the others. And they're going to say, well, why didn't you do this? Right? They're going to go, why didn't you do this? That's crazy. That's sort of what you should be thinking of. A priority action means I had to do this before I could go home. So do I have to increase CBI flow rate? Well, I don't know if it's an irrigation problem. I mean, it could be. They've got clots, but I don't know that that's what the problem is, because normally if the irrigation is running correctly, it shouldn't really be bright red. So I might need to increase it. I don't know if that's, out of all the other things though, I don't know if that's what it is. Administer antispasmodics. Well, I'd really prefer not to give a medication if I can prevent it. I may have to, but it doesn't seem like it's the priority right now, because the continuous bladder irrigation is supposed to control for some of that. Evaluate the patency of the catheter. So if they have a lot of clots and it's red and they're spasming, what I say to myself is, I wonder if the irrigation is running correctly, because I may need to turn it up. But if I turn it up, but it's not even running correctly, like the patency of the catheter is not great, that's not going to help, is it? I mean, it seems like I have to evaluate the patency of the catheter. So out of A, B, and C, I like C best, and then notify the surgeon. So there's sort of a rule on the NCLEX. If there's something you can do that is correct before you notify the surgeon, you should do it. And it would be appropriate to evaluate the patency of the catheter before you notify the surgeon. In fact, probably A, B, and C would all be appropriate to do before you notify the surgeon, to be honest. But the rule is, if there's something you can do that is a correct intervention before you notify the physician, you should do it. That's the rule on the NCLEX. Which dietary instructions are appropriate for a client with stage 3 chronic kidney disease? All right, limit protein intake to 0.6 grams per kilogram per day, restrict sodium to less than 2 grams a day, encourage high potassium foods, limit phosphorus-rich foods, daily fluid intake of at least 3 liters, discontinue calcium supplements. So I wanted to do this because there are a lot of dietary issues with kidney disease. And I think that you're likely to get maybe some dietary questions on the NCLEX. And sometimes it's hard to memorize all that stuff. So you should know that limiting protein intake is appropriate. And I did tell you it's 0.8 grams per kilogram per day, right? So I like A, that's limiting it. That's bringing it down a little below normal. So I like that. Should they do a low sodium diet? Well, they have a tendency to retain fluid because they're in chronic kidney disease. So they have a tendency to retain. So if I give them sodium, that could cause more fluid retention. So it seems like a good idea to restrict sodium. So 2 grams a day is considered a low sodium diet. So less than 2 grams is a pretty low sodium diet, but that's okay. That's still okay to do that. High potassium foods. I told you they have a tendency to retain potassium. So I don't want to encourage high potassium foods. So I don't like C. Limit phosphorus-rich foods. Now, if I didn't know the answer, like if I just didn't know, I would probably pick this one, because I would say to myself, well, they have a tendency to retain electrolytes. And D is actually a right answer. And I said, don't review questions if you get them right. But I'm going to go ahead and teach you this fact here. So the reason we limit phosphorus-rich foods is because there tends to be a loss with chronic kidney disease. They have a tendency to lose calcium in their bone. There's a higher breakdown of their bones, various pathological reasons for that. I don't have all that memorized, but they have a tendency to break down their bones, lose more potassium. And phosphorus, intake of phosphorus limits calcium absorption. I think that's what it is, limits calcium absorption. So we do want to limit phosphorus-rich foods. And it's not because they have a tendency to retain phosphorus. It's because phosphorus stimulates the loss of calcium, and we don't want to lose more calcium. So I don't know if you understood that. I hope you did. So D is actually a true statement. Daily fluid intake of at least 3 liters. Y'all, if you don't know this, the normal fluid intake, recommended fluid intake for a healthy adult who has no fluid volume overload, and they're not dehydrated, they're just normal, is 2 to 3 liters a day. So this patient's already going to have a problem with fluid volume overload because they have chronic kidney disease. So I'm not going to tell them to drink more. The definition of pushing fluids is actually a clinical term. The definition of pushing fluids is more than 3 liters a day. I'm not going to push fluids for a patient who's chronic kidney disease. Discontinue calcium supplements. Well, no, I don't want to do that. First of all, I wouldn't do it without an order, but they have a tendency to be low calcium. So I don't want to do that. So what am I going to do? Limit protein, restrict sodium, and limit phosphorus-rich foods. I'm not going to encourage high potassium because they have a tendency to be hyperkalemic. I'm not going to increase daily fluid intake because they have a tendency to be fluid volume overloaded. And I'm not going to discontinue calcium supplements because they need the calcium. A patient with suspected renal colic reports sudden severe right flank pain radiating to the groin. Which intervention should be done first? Sorry for the typo. Which intervention should be done first? Now, it's a first question, not a priority question. So that does matter. You just say which one. You can like more than one answer. We go what I want to do first. Administer PRN morphine. Encourage increased oral fluids. Strain all urine. Obtain a non-contrast CT scan. Okay, he's coming in. I'm going to say he is coming in with suspected renal colic. Renal colic is kidney pain, almost always associated with kidney stones. Okay, so when I see renal colic, you're allowed to think this patient has kidney stones. That's why they're telling you they have renal colic. So I go, well, they probably have kidney stones. And I know kidney stones are some of the most painful things out of people who've had them. And they've had other things happen like that where you would expect would be painful. Most people will say kidney stones were the most painful thing I've ever experienced. So I know it's incredibly painful. And it says he has severe right flank pain. So that's expected with renal colic. So what would I want to do? Would I want to administer PRN morphine? Yes, he's having pain. Would I want to encourage increased oral fluids? Actually, I would, because we want to try to flush that out. Do we want to strain all urine? Yes, because we want to catch it if the stone comes out. Do we want to obtain a non-contrast CT scan? Not without a doctor's order. So I'm going to cross off D. I mean, we might get that, but I'd need to call the doctor for that. So I'm not going to do that. So the question is, what should I do first? Sharon, how could you know what to do first? You know what to do first because there is an actual problem in the question. You want to answer the question that's being asked. They're asking you what to do for severe pain, y'all. This is an acute actual problem. And what do we do for severe pain? We give pain medication. And remember, it's one of the most severe pains out there. So we give morphine? Yes, we do. And what I want to give something for the pain? Yes, you would, because it's an expected pain. We manage the pain with morphine. That is an appropriate intervention. We want to manage the actual acute problem, and then we can do the other things. A client with chronic kidney disease has stage 4, has a BUN of 52, which is high, quite high, and a creatinine of 6.8, which is very high. Which intervention should the nurse implement first? Provide a high protein diet, assess for signs of fluid overload, administer erythropoietin injection, encourage liberal potassium intake. So chronic kidney disease, I'm already going to cross off A, we don't want high protein. I'm going to cross off D, encourage liberal potassium intake. So I can automatically cross those off. So do I want to assess for signs of fluid volume overload? Yes, because they're prone to fluid volume overload. Would I want to give erythropoietin? Erythropoietin stimulates the production of red blood cells, which they tend to be anemic because normally the kidneys secrete erythropoietin, and when they're chronic kidney disease, they have low erythropoietin, so they're anemic. So do we give erythropoietin? Yes. So what do we want to do first? So I would say, well, I would assess for signs of fluid volume overload and then give the erythropoietin, or I'd give the erythropoietin and then assess for signs of fluid overload. If they told me that the hemoglobin was like 3.2, y'all, I would give the erythropoietin first. I would, because that's an actual objective problem, physiologic problem, and I would do that first. But they don't even tell me what the hemoglobin level is. So I don't even know if it's low. It probably is. but I don't know how low it is. I doubt it's 3.2, or they would have told me that. So I do want to give erythropoietin, but for this person, based on what they've told me with this really high BUN and creatinine, I want to assess for signs of fluid volume overload. So that is kind of how you determine that. They don't tell you. Remember, you do have to know what erythropoietin is for, and realize they didn't tell you what the hemoglobin was or the red blood cells. So like, I can't choose that when I don't even know what those levels are. A 45-year-old woman with autosomal dominant polycystic kidney disease asked which activity to avoid. Your best response is what? All right. Doesn't matter that it's autosomal dominant. Okay. Autosomal dominant just tells me it's chronic. Okay. This isn't acute. So polycystic. So they have cysts on their kidney, multiple, many cysts on their kidney. Ask you about activities to avoid. Okay. Swimming in a chlorinated pool, lifting heavy weights, walking briskly, or gentle yoga. So this is not something I expect you've memorized. I certainly haven't memorized it. So you have to use clinical reasoning to figure this out. So I say polycystic kidney disease. All right. Is there any way chlorine can get into the body and harm the kidneys? Well, you're not supposed to drink the water. It doesn't say it's like a 6-month-old. It's a 45-year-old woman. She's not drinking the water, and it's not going through her skin. It could dry her skin out, but other than that, so I don't see how that could be a problem. Lifting heavy weights. All right. Y'all, lifting heavy weights is not a good NCLEX. I mean, it's not a good thing to do on the NCLEX. I'm not saying we never recommend people lift heavy weights. It's just not a good activity to recommend on the NCLEX. I'm just telling you. I'm just telling you how to think on the NCLEX. When I think heavy weights, I think increasing intra-abdominal pressure. I think the kidneys are in there somewhere. I just don't know. Like, it doesn't sound good to me. Okay. Walking briskly. Any reason to not walk briskly? It doesn't say running as fast as you can. It says walking briskly. Like, people can walk briskly. I don't see why they couldn't do that. Gentle yoga. Well, definitely gentle yoga is fine. Like, it says the word gentle. Like, that's just a good activity on the NCLEX. You've got to learn how to read this. It's not necessarily about memorizing the right answer here, because it's not about that at all. It's about thinking the right way and knowing how to think on the NCLEX. And I go, well, these words like walking briskly and gentle yoga, these just sound like good things to do on the NCLEX. She's 45. She's not drinking the pool water, and lifting heavy weights. It's just not something that I usually recommend people do on the NCLEX. So I'm picking that. And that sounds like something she should avoid. Select all appropriate nursing interventions to prevent CAUTIs, catheter-associated urinary tract infections. All appropriate nursing interventions to prevent CAUTIs. Maintain a closed drainage system, cleanse perineum with antiseptic solution daily, keep catheter bag below bladder level, irrigate catheter with sterile saline every shift, use sterile technique during catheter insertion, discontinue catheter tubing to empty the urine every 4 hours. Discontinue catheter tubing. What? No. No, I didn't say that right now. Let's not do that every 4 hours. Okay, that's just going to introduce bacteria. We want to prevent CAUTIs. So I'm crossing off F right now. Maintain a closed drainage system. Yes, that's a major one. We definitely want to do that. Cleanse perineum with antiseptic solution daily. Y'all, there's a red flag here, and it says antiseptic. Do you know what I usually see as the right answer? Cleanse with soap and water. That's usually what they usually just say soap and water. And I go, what's an antiseptic solution? Do you know that I had to look it up? Okay. I looked up the word antiseptic. And do you know what it means? It means absence of bacteria. Absence of bacteria. So if you use an antiseptic solution, it means you're killing all the bacteria on the skin. Now you might go, well, that's good. Yeah, but y'all, I've said this before, you don't get credit on the NCLEX for doing more than you have to. You don't get credit on the NCLEX for doing more than you have to. And antiseptic is like chlorhexidine. Okay, it's like chlorhexidine. When we don't do perineal cleanses with chlorhexidine unless they're going for surgery, and you don't get credit for doing more than you have to. So I don't like B. Keep catheter bag below the bladder level. Yes, because that way it drains down. It doesn't drain back into the bladder. Irrigate the catheter with sterile saline every shift. Y'all, we don't irrigate the bladder. We don't irrigate it. We do it with prostate surgery. Sure, but this isn't prostate surgery. Okay, they've just got a catheter, so we're not irrigating it. Use sterile technique during catheter insertion. Well, yes, of course, you know that. Okay, so A, C, and E are the correct answers. I hope you understood that. I'm not going to go back through it. My dogs are whining over here, so if you hear it, just ignore them. A patient reports sudden loss of urine when coughing and sneezing. Which statement by the nurse indicates correct understanding? Sudden loss of urine when coughing or sneezing. Okay, y'all, this is just, different types of incontinence. Urge incontinence, overflow incontinence, stress incontinence, functional incontinence. So urge incontinence, have you seen that commercial? Gotta go, gotta go, gotta go, gotta go. That's usually associated with bladder spasms. And that's urge incontinence. Overflow incontinence is when a person no longer has the neurologic ability to sense that their bladder is full. So that happens sometimes with stroke. Sometimes that happens with spinal cord injury. It can happen with neuropathy associated with diabetes. So that's overflow incontinence. Stress incontinence is increased intra-abdominal pressure that causes you to lose urine. That's exactly what coughing and sneezing is. Functional incontinence is just like, y'all, that's just they're incontinent. Like, who knows why? They just are. I don't know. They're confused. They're old. I don't know. But it's not functional incontinence. Stress incontinence is the correct answer. Which interventions help prevent calcium oxalate kidney stone formation? Encourage 2 to 3 liters of fluid intake a day. Limit oxalate-rich foods. Restrict dietary calcium to less than 400 milligrams a day. Administer thiazide diuretics as prescribed. Increase sodium intake to prevent calcium reabsorption. Advise a low-protein diet. Okay, so we're talking here about kidney stones. Calcium oxalate. So I may say, well, I don't know much about calcium oxalate specifically. So I'm kind of think generally, right? I'm going to just think about kidney stones. These happen to be calcium oxalate kidney stones. All right. So encouraging 2 to 3 liters of fluids intake a day. So staying hydrated, is that important? Yes, it is. To prevent kidney stones, you got to stay hydrated. Don't let yourself get dehydrated. Limit oxalate rich foods. I don't know much about calcium oxalate kidney stone formation, but it tells me specifically that it's an oxalate stone. So it seems reasonable to limit oxalate rich foods. Like, I'm just going common sense here. Okay. Don't throw your common sense out the window. Restrict dietary calcium to under 400 milligrams a day. So there is one thing I know, and that actually limiting calcium doesn't actually help prevent calcium stones. You have to stay hydrated is more important, because if you limit calcium, you're going to start to lose it from your bones. And then you can still get kidney stones, right? So usually restricting calcium just doesn't help with calcium stones. Administer thiazide diuretics as prescribed. All right. I don't know why thiazide diuretics would help. I'll be honest with you. Like, if I'm reading through this and I go, do thiazide diuretics help? I don't know. But there's a key word here that makes it a good NCLEX answer. It says as prescribed. Whenever they say as prescribed, I'm like, maybe I should pick it. So I may not necessarily know, y'all. I'm doing a really good job acting clueless, right? I am, aren't I? Not much acting involved. Right. So I may say, I don't know why thiazide diuretics would help, but it says as prescribed, and I'm always going to give as prescribed. So I'm picking it. Increase sodium intake to prevent calcium reabsorption. I don't usually recommend we increase sodium. I don't know any relationship between sodium and calcium. Advise a low protein diet. Anything, y'all, this is kidney. Anything related to kidney, I pick low protein diet. I just got to admit, right? We're using, I'm telling you that you don't have to memorize everything. So you got to think generally. So it's kidneys. So I like low protein diet. So it turns out that knowing how to use testing strategies, like saying it's a good NCLEX answer when it says as prescribed, it's kidney, so we're going to go low protein. I'm not saying you're going to get them right 100% of the time. What I'm saying is that when you're not sure and it makes sense in this context, like associate with this body system, it makes sense, or they use words that NCLEX likes these words, like it just makes sense, right? Oxalate rich foods, you got a calcium oxalate kidney stones, stay hydrated 2 to 3 liters. So these are just common sense answers. I'm not telling you to go out and memorize calcium oxalate kidney stones. I didn't. Select appropriate nursing care measures for an indwelling urinary catheter. Now, we already had a question like this. So let's see how different this is. Secure catheter to the inner thigh, cleanse perineum and catheter insertion site daily, use soap and water for perineal care, keep drainage bag on the bed beside the patient, empty the bag at least every 8 hours or when half full. Apply sterile dressing around the catheter site. All right, so it's the same question, just different answers. So you've got to understand that SATA questions are involved with what are asking whether you understand principles. SATA questions are not whether you memorize the list. Okay, it's not about memorizing a list. It's about understanding principles. That's always what SATA questions are. So don't go, I didn't memorize this list. No, you got to think. You just got to think clinically and use common sense. So do we secure it to the inner thigh? Yes, we do, right? So it doesn't pull on the perineal area. So we secure it to the inner thigh, cleanse perineum and catheter insertion site. Yes, it doesn't say with antiseptic solution. It just says cleanse it. You're like, yeah, of course we're going to do that. Use soap and water. Remember I told you most of the time they just say soap and water, not antiseptic. I like soap and water. That's what we're supposed to use. Keep the drainage bag on the bed beside the patient. No, it's got to be below the level of the bladder. Empty the bag at least every 8 hours or when half full. Yes, that's a good NCLEX answer. Apply sterile dressing around the catheter site. No, I hope you don't think that's the right answer. Okay. Select all appropriate patient teaching points for a client starting oxybutylene for overactive bladder. Expect dry mouth, sip water frequently, report blurred vision immediately, avoid driving until the response is known, increase fiber intake to prevent constipation. This medication will increase urinary frequency or heat intolerance may occur. Avoid excessive exercise. Now, it doesn't say avoid exercise. It says avoid excessive exercise. So that's a pretty good NCLEX answer. All right, here's where I told you I'm going to teach you a little clinic strategy, okay? All right, so first of all, we talked a little bit about urge incontinence. Gotta go, gotta go, gotta go, gotta go. I don't think that commercial's on TV anymore, but it used to be on all the time. Gotta go, gotta go, gotta go, gotta go. That's a spasming bladder, urge incontinence. You feel like you got to go and you can't wait because a spasm occurs and you got to go. All right. So did you know it's the parasympathetic nervous system that actually constricts the bladder? The parasympathetic nervous system is the rest and digest. The sympathetic nervous system is the fight or flight nervous system, right? The sympathetic nervous system is the fight or flight. Why would our sympathetic nervous system cause the bladder to relax? Because when the bladder relaxes, you don't have to go to the bathroom. You can hold more urine, right? And you don't think your sympathetic nervous system is activated in the middle of a code blue. Okay, you're working at the hospital. You're already a little stressed, but now all of a sudden your patient's heart stops, like super stressed, right? Your sympathetic nervous system, epinephrine, fires, your heart rate goes up, your bladder relaxes because you don't want to be imagine doing contractions. And you're like, oops. Every time you do contraction, you have a little bit of oops incontinence, right? Because oh no, like you don't want that, right? Like you don't want to have that happen. Okay. So what happens is it actually causes your bladder, the sympathetic nervous system causes your bladder to relax and it decreases gastric secretions and peristalsis because you don't want to have to poo in the middle of a code blue either, right? That's why your mouth gets dry. Your mouth is dry. You're a little constipated. You feel like you can't really go. Takes a minute to you sit down to go to the bathroom right after code, and it's going to have to sit there for a minute because it's going to take a minute to be able to relax those sphincters and contract the bladder, right? Because the sympathetic nervous system causes all that to happen. It's the parasympathetic nervous system, the rest and digest nervous system that actually constricts the bladder, increases gastric secretions, increases peristalsis, so you have more fluid in your mouth, okay? So having said that, the primary neurotransmitter for the parasympathetic nervous system, which contracts the bladder, is acetylcholine. So if we want to stop the bladder from spasming, we could give epinephrine because epinephrine will prevent it from spasming because that's a sympathetic nervous system. That's a little aggressive, y'all. I don't want to be incontinent, so I'll give you some epinephrine. And then you're like, right? So let's not do that. So instead of giving epinephrine, what we're going to do is we're going to block the acetylcholine. What is it called when we block acetylcholine? Remember, because acetylcholine causes the bladder to contract. We block it. That's called an anticholinergic. So oxybutylene is an anticholinergic, and it has anticholinergic side effects. Now, here's the tip to remember from Climic. When you think anticholinergic, think dry and dilated. Anticholinergic, dry and dilated. Dry mouth, dry GI tract, The bladder can't excrete any urine, right? So dry mouth, constipation, urinary retention, and so that's dry, and dilated pupillary dilation. Do you remember when you used to get your pupils dilated when you went to the eye doctor and they dilate it so you can look in the back of your eyes? What's your vision like when you leave? I can't see anything. Everything's blurry, right? I mean, you can drive home because distance vision is actually not too bad, but you can't see anything up close at all. And so blurred vision. So dry and dilated, blurred vision, and bladder retention, constipation, dry mouth. Okay. All right. So select all appropriate patient teaching points for a client starting oxybutylene, which is an anticholinergic for overactive bladder. So let's look at the answers. Expected dry mouth. Yes. Sip water frequently. Yes, that's an appropriate intervention because it's dry and dilated. Report blurred vision immediately. All right, y'all. You expect blurred vision. It's a side effect. There's going to be some databases that probably will disagree with me, but on the NCLEX, this is the way it is. You don't report expected side effects. The nurse teaches the patient how to manage those side effects. You don't have to report them immediately. I would teach them expect blurred vision. Because you're going to get blurred vision, don't drive until you know how it's going to affect you. So C, avoid driving until the response is known. That's a true statement. Increase fluid intake to prevent constipation. Yes. Dry and dilated. So increase fiber. Yes. This medication will increase urinary frequency. No. Dry and dilated. Heat intolerance may occur. Avoid excessive exercise. So I think, well, could heat intolerance occur? I mean, let's see, if we're anticholinergic, yeah, I guess that could happen because it's sort of like revving up your sympathetic nervous system. So you could have some heat intolerance. And it doesn't say avoid exercise. If it said avoid exercise, I wouldn't like it. But avoid excessive exercise, that's an okay NCLEX answer. Okay, so those are the correct answers. May not agree with me on all of them, but I'm teaching you how to use good clinical reasoning and common sense to pass NCLEX. This went a lot longer than I thought it was going to go. I'm going to make the next one shorter. Okay. So I hope you have a great rest of your day, and I'll see you later. Thanks for being a part of the Clinic Review family.